We're going to talk about osteotomy, uni, total knee. So I want everyone to raise their hand if they do total knees of the panel. Everyone raise their hand if they do unis. Everyone raise their hands if they do osteotomy. All right. But you did osteotomies at one point. All right. So we're going to talk about the varus knee. The varus knee is what I do for a living. And the varus knee is what everyone does for a living. Where do we intervene on that varus knee is really what orthopedic surgery is all about. So we'll talk about indications, alignment goals, recovery time, activity level, and longevity. And really what I want to focus this session on, what do we tell our patients, and what's the level 5 evidence, which means what you tell the patients, and what's the real evidence. Okay, so this is really what we're talking about. First, let's talk about osteotomy, because when I was a young resident, I saw 0 osteotomies HSS. And my dad's friend, Harry Belafonte, didn't have a knee replacement. He had a closing wedge osteotomy that lasted his entire life. So we're seeing a renaissance of osteotomy. And while we love osteotomy, well, it preserves the cruciates. But if the cruciates are out, I don't matter. I can adjust the slope. It helps my collateral surgery. And when I say it, when you have an osteotomy, I can say, you can jump out of an airplane, you can play professional sports, you can do whatever you want, you can run on it. Things that we probably don't ever say about an arthroplasty. However, still osteotomies are still going down, and arthroplasty is going up. So I wonder that issue. And unis are exploding. It's a shorter operation, a quicker recovery. It gives you a more normal kinematic knee. And with better technology, we're better at doing the operation. When I brought the robot here 15 years ago, you all thought I was crazy. Now there are robots everywhere out there. So it's fascinating to see the evolution. So then the answer is always going to be total knee, total knee, total knee, total knee. And my brother, for his indications conference, it's pretty simple. It's total knee, or maybe a total knee. That's not my indications conference. But realize the cost of total knees are going up, the revision burden is going up, the economic burden going up, and it still has a higher mortality and a higher morbidity. But no one's saying it's not the gold standard for severe OA. So now let debate begin. Let's go to the panel. Okay, so I'm going to walk down the panel. Let's start on Sachin and come towards me. Okay, you're allowed 3 sentences. Not 4, hopefully not 2. So what are your ideal indications for an osteotomy, Sachin?
So for me, an osteotomy is someone who has got a bony deformity. His deformity needs to be in the bone. That's sentence number 1. Sentence number 2, he should not be bone on bone. And 3 is that he should want to lead an active lifestyle.
Parag?
Yes, so for me, UKA is only when it's bone on bone and...
No, osteotomy.
Okay, talking about osteotomy. So osteotomy when there is no bone on bone, as Sachin said, and it is a deformity more in the metaphyseal area, and which is demonstrated when you do the long leg x-rays, the CT scan, and you can see that, and by doing the various angles. So that's HTO for me.
Sachin, I want to go back to you. You said it has to be not in the joint. So if you have early varus deformity, and most of your deformity is from the joint, you have early chondral wear, you're saying you can't do an osteotomy?
Yeah, that's correct. So if you have normal bone angles and you have an isolated intra-articular deformity, it is unlikely that your osteotomy is going to be successful in this particular aspect, because with the bony correction, you can correct metaphyseal deformity. It does not act, it does not give the same kind of beneficial effect on isolated.
Right, so you would, but you wouldn't do it.
Sorry?
You wouldn't do it. So Dr. Reef,
yeah.
You have early chondral wear. Does offloading that compartment help early chondral wear?
I believe it does. Osteotomy is done typically when there's a bone deformity, but it really is correcting alignment. So if you correct alignment away from that chondral wear, patients often feel better.
So Sachin, I think you're saying you prefer more of a coronal deformity, but it doesn't mean it's a contraindication to do it for early chondral wear. Because if you go to Japan, they would disagree with you. They could show studies where they regrow cartilage.
That's true. But then I think to try and create a deformity in the opposite direction when the leg is neutral is not a great idea.
Right.
Yeah.
Well, we'll get to alignment. Arun, what is your ideal indication for a uni?
Bone-on-bone contact, medial, anterior-medial OA, that's it. An intact ACL. That's all I need.
Anoop, can you do a uni without bone-on-bone contact?
Yes, especially in spontaneous osteonecrosis of femur. That's one indication. And yes, so there are other indications as well.
Selective, but it still doesn't. So, but how about early OA? Would you do a uni for early OA?
No, not if the lateral compartment is involved or if there is patellofemoral arthritis, no.
Okay. Next question. What about the patellofemoral joint in unis? Do we really care about the patellofemoral joint? Because all I hear from these people, they can resurface the patella, they don't have to resurface patella, everybody has anterior knee pain anyway. What do I care about the patellofemoral joint with the uni?
Two things I care about in patella. One is whether the tracking is okay or not.
Okay.
Even if there is a little OA of the patellofemoral component, with good tracking should be okay for the unicondylar knee replacement. But what I really worry is whether you have the lateral facet, which is bone on the bone erosion. You have a lot of involvement of the lateral compartment is going to be a contraindication for my patellofemoral OA for the partials.
Yeah, so I think, early conjugal patellofemoral joint is probably not a contraindication. Arun, you have a question? You have a point?
Yeah, bone-on-bone contact between the trochlea and any part of the patella, contraindication, and lateral facet as well as lateral subluxation are contraindications.
Okay, quickly down the line.
Medial facet, grade 1, grade 2 changes, no problem.
Sachin, do you need an ACL to do a uni?
The ideal answer is yes, but we have recent data that shows that if you do not have an ACL, then if you use a fixed bearing uni and you adjust the tibial slope to 3 to 4 degrees, then you get equal survivorship of your uni. So if you're doing a mobile bearing uni, well, ideally you should have an ACL. If you're doing a fixed bearing uni, then if you do not have an ACL, you have to ensure that the slope is 3 to 4 degrees and no more than that.
And so does everyone agree that although for a fixed bearing uni, you can get away without an ACL, but it's still suboptimal? Everyone agree with that? Because that would not be the answer 5 years ago, right? All right. Good. So look, we talked about this. This is, my ideal indications for a uni. For an osteotomy. Here's my ideal indications for a uni. Let's talk about body weight and an osteotomy versus uni. Taylor, what do you care about BMI?
I don't. I think there's a lot of heavier patients who develop arthritis and they still do great with osteotomy. The alignment correction is powerful.
Arun, what about a uni? Do you care?
For mobile bearing unis, there's really no evidence that BMI matters, but I think common sense
You believe
dictates,
everything you read from Oxford?
Most of it, but I tailor it to our patients' condition, and most of them, if some of them have significant osteomalacia, osteoporosis, they're short, then I might rethink doing a uni. But otherwise, I'm not terribly concerned.
Anoop, what about body weight?
Yeah, so some of these patients, apart from body weight, have metabolic syndrome. And metabolic syndrome leads to progressive arthritis. So I would guard my patients, especially if they've got significant high BMI.
Well, I do worry about the obese patients with high BMI. And in my current practice, I do think that, the uni in these obese patients may have an inferior result compared to the patients who BMI is within a lower limit. And that's why I think I'm very careful in choosing these patients if I'm going to do in obese patients.
The reality is obesity is bad for every operation. An osteotomy is probably the best operation, but I would always err more on the total knee than a uni because that little piece of cement is all they have. Versus the total knee, I have more cement or more fixation to hold. Okay, osteotomy. Sachin, what's your ideal alignment goals for an osteotomy?
So if it's an osteotomy that's done for a ligamentous problem, my ideal sort of alignment is going to be 52% or just beyond the neutral on the valgus side. If I'm looking at an arthritic patient, then my ideal alignment is around the 54 to 56 percentile point, which is on the downslope of the lateral tibial spine. If I'm doing a uni, I want to leave the knee in about 2 to 3 degrees of varus. If I'm doing a fixed bearing, if I'm doing a mobile bearing uni, then it's as much as the intra-articular deformity correction will allow.
Parag, what's your goal for an osteotomy versus
I
uni?
agree with what Sachin has said, but just to add on, it depends on whom you ask this question, and later on in the day, we are going to talk so much about alignment. So the alignment means different things to different people. For a knee replacement person, if you are trying to reproduce the native alignment, and that's all kinematic alignment about, then it's different. But here, I would say that I would like to go a little more than neutral to the Fujisawa point when I'm doing an osteotomy in a young non-arthritic patient. For an arthritic patient, you know, I'm not yet sure whether kinematic alignment works, it doesn't work, but I'm getting there. All I would like to say is that if it is too much in varus, you know, leave them a little bit in varus, what we call as the adjusted mechanical alignment. That's the goal, and that's similar for uni.
Right. So Taylor, we were taught Fujisawa's point, is that the holy grail? Sachin's saying it's not. So do you tailor your alignment based off different types of osteotomies?
Yes, this is a very individualized, tailored to the patient answer. You know, I think Sachin gave a great answer that, you know, anywhere between 45 degrees if you're trying to leave, or 45% if you're trying to leave a little varus, up to 55%, you know, if you're trying to offload a compartment. I've always thought Fujisawa's point was a little aggressive, and I think that was really for a very arthritic knee, you know, coming out of Japan. But yeah, somewhere in that 45 to 55%, depending on what patient and what their goals are.
Right. So I would say it's a clear thing that saying Fujisawa's point was based off bone-on-bone arthritis, probably outdated data. We're all tending to undercorrect, especially for the younger patient. No female likes to be overcorrected. So, but at the same time, if you do an osteotomy and you undercorrect too much, probably not a good operation either. Arun, I was taught neutral, neutral, neutral. There's tibial spine, split the uprights for a total knee. Then I was taught for a uni, maybe we undercorrect. Now a total knee is sounding more like a uni. What the hell am I supposed to do?
My philosophy for unis and total knees is completely different, because in the uni you have the ACL which is intact, and in a total knee you don't. So therefore the indications are different of what alignment I'm aiming for. In a uni, it's pure natural alignment. Whatever is the pre-arthritic alignment of that patient is what we have shown in our publications, that gets restored. Once you do a uni, no soft tissue release, you just remove the osteophyte and balance your gaps. The alignment you get will be that patient's pre-arthritic alignment, whatever that was. If it is the more severe the deformity, the more the residual varus that you'll end up with. The problem is actually when the deformity is very minimal, that's where you run the risk of overcorrection and causing transfer arthritis. In a total knee, of course, I think we're going to be talking about alignment later on, so we'll probably skip that.
But just answer one question. Can you put a total knee into varus?
Yeah, most of the time I do keep my varus knees in a little bit of varus, yes.
All right. My dad's scratching his head somewhere. Anoop, what's your philosophy? Uni, total knee. Are they, do we put them both in 3 degrees of varus? Or do you still want to put more valgus on your total knees?
Yeah, so kinematic alignment for both. Recreate the pre-arthritic joint line and leave them in the pre-arthritic varus. So usually my uni would be in 3 to 4 degree varus.
Can I ask you guys, what percentage of your patients do you have x-rays before they have arthritis? How do I know what they're, I mean, in India, do you just know? Oh, that's 3, this guy was 6, this guy.
No, it's not the x-ray. It's cutting the bone equally in a total knee, cutting 8 and 6, 9 and 9. Right. So it's recreating the pre-arthritic joint line on the table.
For the partials, I will not overcorrect, I will not undercorrect. So the varus about 1 to 4 degrees for most of them for the medial, and I never overcorrect. And for the totals, it's a functional alignment less than about 3 degrees of varus for most of my knees.
Sachin, osteotomy, when do you tell the patients they're back to their ADLs?
Okay, so again, this is a very mixed cohort if you look at osteotomies, because the indication for an osteotomy may be all over the place. So typically an osteotomy combined with a ligament surgery, the ADLs roughly around 4 to 6 weeks, and return to sport only after, or return to light sport only after 9 months. Osteoarthritis alone, osteotomy, ADLs back at about 4 weeks, and return to light to moderate activity after about 9 months.
So 4 to 6 weeks, that's pretty, Parag, when do you tell your osteotomies they can go back to ADLs? 4 to 6 weeks seems a little bit rosy.
So I would say minimum 3 months is what I tell
Yeah,
them,
I would think that's a little more.
and anywhere up to 6 months max.
I do think the closing versus opening wedge makes a difference.
Sure.
Closing wedges tend to get back to ADLs faster, feels more stable faster.
Arun, what do you tell your unis when they can get back to ADLs?
You don't have to tell them, they will get back to their ADLs. As soon as they're comfortable, most of them will recover and
But
do
they-
whatever they want.
They asked you, when am I going to go back to my ADLs? Because
Oh, well-
I'm a uni versus a total knee. So they're going to ask you every time, when's the uni go back to ADLs and when does the total knee go back to ADLs?
I think total knees take a little longer than unis in general, but I don't have any specific restrictions for unis. I tell them not to sit cross-legged on the floor for the first 2-3 months because these are mobile bearings and they're prone to dislocation. So that's the only restriction I have. Otherwise, and I don't allow them to run no impact activities. Other than that, they're allowed to do everything from day one.
Right, but I'm not giving you restrictions. I'm saying, when am I back to working in my normal life? Give me a week. In America, they ask you, when am I go back to work?
2 weeks.
2 weeks
I tell
for
them
uni?
that you can return to work in 2 weeks. For example, we've done doctors, politicians, etc. In 2 weeks, they're all back to work.
And what about a total knee?
Total knee generally takes around 4 weeks minimum. A lot of them have to climb stairs where they go, and they find that difficult for the first month. They need to drive, so I'll allow them to go after about 4 weeks. So I
Anoop,
give them
that-
a time period of about 4 weeks.
That seems a little rosy to me. What do you tell your patients? Uni, total knee, return to work.
4 weeks, 6 weeks.
4 weeks, 6 weeks, so it's a 2 weeks difference.
Yeah.
4 weeks for a uni, 6 weeks for a total knee.
Yeah.
It actually depends on what kind of the ADL they have.
Right.
Most of our patients are either housewives or working at home.
Right.
And most of them go back to their kitchen in about 4 weeks' time. And if they're a desktop job, which is not that common, is around 4 weeks again. But more than that, it's going to be after 6 weeks or 8 weeks' time.
Okay, so let's talk about activity level. Sachin, what's the highest activity level? What do you tell a patient after an osteotomy? What can they get back to?
So I think
You said 9 months, they're back to sports. What does that mean?
So I think I'm looking at doubles tennis. I'm looking at maybe hiking, a short hike, and that's what I'd advise them. Because
Sachin, can I run after my osteotomy?
can you run? You could run, but that's the exception rather than the rule. I mean, normally you'd see that these patients have come to you with some sort of compromised activities of daily living. They have come because they've got arthritis and their activity level has already gone down. So typically this is what the best that they'll get. So if you look at it on a Tegner activity scale, they're roughly around a Tegner 6 or 7. They can never go to a 9 or 10.
Parag, do you agree with everything Sachin said?
Yeah, so I would allow them to run. It depends on what indication the osteotomy is done for. If it is a non-arthritic knee, if it is a ligamentous thing, they definitely can get back to what they want to do, including running or even something more. But if it's an arthritic knee for which you're doing an osteotomy, then of course I would like to restrict them, but jogging is all right with me.
I think Sachin and Parag, you're saying different things. Sachin's saying it's unlikely that they'll get back to running. You're saying you'll let them run. So those are two very different statements.
So if it is a non-arthritic knee and the osteotomy is done for ligamentous reasons, surely, once you get them back. But if it is an arthritic knee, I will see what he can do and what he cannot do. If he wants to do slow jogging, I wouldn't restrict him. Because anyway he's going to do it. Even if you tell him not to, the patients don't listen to you.
Taylor, in your experience, what's your return to higher level sports after an osteotomy? What do you tell your patients?
Yeah, I tell them they certainly can return to that. It does take 6 to 9 months, but I think the sky should be the limit and it should be patient determined. And I will say, this hasn't been mentioned yet, but they're going to return to their highest activity level when the plate comes out.
Arun, you kind of implied before that you're not letting your unis run. Are you letting, if a patient comes to you with meal compartment OA and goes, I want to run, will you not do a uni on them?
Yeah, I wouldn't.
Anoop, what about you? Do you tell your patients that they can run?
Yes, they can. A lot of my patients do, actually.
What percentage?
A lot of our patients don't want to run in our country. Running is not a great hobby in India.
Okay.
So, in this room,
What about cupboardy?
Yeah, no. So
What about
most of them want.
What's the return to cupboardy in India?
So Anil, most of them want to sit on the ground and do yoga.
Right.
That's the common want in our country, and all of them can do it. Uni patients.
Nobody would like to run, and not many will play kabaddi either. And most of my patients, I tell them that the repetitive impact activities like skipping, running, and probably the high level of sports are not allowed because of the polywear. They are okay with the lighter sports, something like a table tennis, swimming, cycling. But most of my patients, as Dr. Jurani was saying, is they are not into sports and they just would like to get rid of that medial joint pain. So they are okay to get back to most of their activity.
Anoop, you have one question?
So we had Anand Joshi, who's an arthroscopic surgeon who wanted a medial uni, and he said, I'm not going to stop running. So I said, okay, then I'm not doing a uni, and that's how he had an HTO.
We have to go. One last question. Sachin, if you were an ideal osteotomy candidate, and I want everyone on the panel to say, would you get an osteotomy for yourself?
Yes, I would.
Parag?
Yeah, I would get an osteotomy done.
Taylor?
Absolutely.
Anoop? Arun? Everyone?
Yes, yes. If I was an ideal candidate, yes.
Not an osteotomy, I'd go for a uni.
All right. But you don't have bone-on-bone arthritis. I said an ideal candidate.
Then I'm,
So you
I'm
say
not
no.
going to do an osteotomy. I'll sit it out.
You say that.
If no bone on bone, no surgery,
Right.
and if there's bone on bone, I will have a uni.
Now, if you are in between a uni, Sachin, and a total knee, what do you want? And remember, this is videotaped, and we're showing this to my father.
So if I'm between a uni and a total knee,
Yeah.
at my age, I'll do a uni.
Right.
I would err on a total knee. I would do a total knee.
Taylor?
Unis seem happier.
A uni by, no question about it.
Yeah, uni, if I'm an ideal candidate for uni, yeah.
Total knee in this country because the longevity is much better with the TKR.
So as you could all tell, we've solved this problem. Everyone knows the right answer. And I will tell you this, my father I always would tell my dad, if a total knee is such an awesome operation, why come, my dad never got a total knee. And he goes, Anil, because I have neutral alignment and low body weight. So the boss is always right. Thank you very much.